And we're back with Erik Meira for round four. Erik, I'm hopeful that people have listened to the other episodes. I'll briefly touch on them. 31, All Things ACL. 77, Foundations of Practice, your course or one of your courses. And then more recently, 116, one of your blogs discussing the SAID principle. All those episodes were awesome. If someone hasn't listened to any of those or somehow doesn't know of you, can you just give a brief background on yourself?
Yeah, I'm a physical therapist for 25, I think, plus years. You just stop counting after a while. But I kind of like to describe myself more as an applied biomechanist because that's more of what I do, I guess. I will have to say that I thought that what I do was physical therapy when I got into physical therapy. That's a whole other discussion that can be had, where the profession seems to be really stuck on things that I'm not particularly interested in. So instead of trying to explain to people, well, I'm not that kind of physical therapist. I'm not going to lay you on a table. I'm not going to, put my hands all over you and do things to you. I'm going to look at, forces and how you're managing those forces. And so I call it applied biomechanics. So, but mostly educator, I think is what I do mostly. So the Science PT blog is where people see a lot of my stuff, and then putting on conferences and that kind of stuff now.
Yeah, when we chatted last, I think it was around a year ago, we had just summarized how that first basketball conference went. Can you touch on like how things have maybe evolved with some of those elite rehab conferences over the past year?
Yeah, so we did I did the first one, which was the basketball one that I just did. I have a lot of contacts and a lot of work I do with the NBA and NBA staffs, and just talking to them, especially the physical therapists, that there was a need for some sense of like community, some kind of conference potentially to do, because they were well organized around athletic trainers and getting fairly well organized with the strength coach side, and there was this kind of gap, specific scientists, in just saying that there's not a lot of crosstalk. And like the athletic trainers are saying, we're getting a lot of good stuff on like acute management, and they have a very well organized group that helps them with professional development and these types of things. But that there was this component that was kind of missing, and that's the physical therapists are kind of the center of that, and how is that kind of communicating out? And so we had all these teams that were, in Las Vegas for Summer League every year. And Summer League's kind of a laid back event. It's an opportunity for younger people within the league to kind of step up and do work. And so it allows some of the more senior staff, and senior staff may only be like 5 to 10 years out themselves. So they're still young and often not getting a lot of opportunities to do presentations, especially with as hectic as their schedules are. And so I was like, oh, well, let me just ask around, and let me see if I can put together some space in Las Vegas, adjacent to Summer League, that I can pull from those NBA staffs, pull from my NCAA connections, get what we can with WNBA. There's a challenge with them because they're in the middle of their season in the summer. That's a whole different conversation as to why the WNBA plays a backward schedule, so to speak, versus the whole rest of the world. And so I decided to put it together, organize it, get some speakers, get some sponsors, put it on, and it sold out in 6 hours. So turned out that there was a need, so expanded it to a much larger event. Now it's close to 200 people that attend. But also at the event, people were really excited about it. They really enjoyed it. But I was noticing in the roster that I had people like from the NHL that were attending, and I was, I went up to those people and like, why are you here? And they said, oh, because when we go to a conference, it doesn't apply to what we do. Like if we go to CSM, for example, nothing is directly applicable to working with an athlete at the level we are. And so, education opportunities are few and far between. And we figured that what was presented at this conference would be more applicable to our day-to-day life, even if it's focused on basketball, than the other ones we go to. And so then it was a question of, do you think hockey would, benefit from this? And And so expanded to hockey and then soccer last year. And then this year we added football that we're doing at the combine coming up in about a month. That one's also going to be a fairly large one. Hockey and soccer tend to be pretty small, like 60 or so people, which is pretty small for a conference. So that's a little more of a personal event. So yeah, that's kind of how it kind of grew. I like to describe it as, I feel like an NCAA athletic department, basketball and football pay for everything. And then we support the other sports.
Yeah, well, that's awesome that it's been able to grow, and now there's 4, and I'm super curious to see how it evolves over the next few years. You're managing that, and then I think last time we talked about you also starting, I believe it was a flight school. Is that correct?
Yeah, working on ground school for pilots because I'm a pilot as well, and I love doing education. And when people are training for their private pilot license, which is the first step you take to become a pilot, most of the ground school is actually done online now with pre-recorded stuff. So working on building out those recordings so that people can do, so that I can offer that as an opportunity as well. Because I wasn't thrilled in the options I had as a student. And you know, I was like, there's ways I could do this a whole lot better, me personally. And I also was kind of geeking out on it and realizing that if I were to teach this, I would learn it all that much better. Because that's been my experience with everything, is the more I teach, the more I learn. And so, look at it as an opportunity for that.
That's great. Okay, let's dive into the topic for today. So the first episode we had you on was this, overarching ACL rehab as a whole, but today is going to be more granular and talking really solely on early phase management and really how important that is to guide the mid stage, late stage, and just the success overall. This early phase, can you just discuss, one, when people say that or when you say it, what does that timeline kind of look like, amount of weeks or months? And then what actually are the really big priorities just to start with in this phase?
Yeah, so in those early phases, it has to do with, the immediate post-op situation. So typically, that's to me at least, that's the early stage. And that's when, you just have all this insult to the knee. The knee is trying to figure out, what's going on. It's swelling like crazy. There can be pain. You may be dealing with the results of a nerve block, all of these things that are the immediate aftermath. And the way I like to describe it to a patient is, as far as your body is concerned, what happened to it is that you had a loss of consciousness, and then you woke up with all this trauma to the knee as it interprets it, which includes like tunnels drilled through the bone. So, as far as like what your body understands in its, very primitive state is like you fell off a cliff, you were mauled by a bear, and it is considered that knee to be a lost cause and non-functional and completely trash. But we actually know that it's been put together and it actually is better. So you start off right away with a fight between the natural state that the body thinks it's in and what the reality is. And that's something that that's a theme throughout rehab when somebody's working with me, is what is perception versus reality of your situation. Because in the early phases, your knee can do a lot more than you realize. And in the late phases, your knee probably can't do as much as you think. And so it's making sure that we keep that perspective the whole time.
Yeah, I like that kind of starting point. And I listed out just a few common things that people discuss or that are typically their priorities during early phase management. And I just want to get your take on these and dive in. But I listed range of motion, managing swelling, obviously monitoring for infection, DVTs, et cetera, waking up the quads and improving gait. I think those are not that much of an argument. And I think most people would be on board for those being really early priorities. But I want to hear your thoughts of like the logistics of actually managing and monitoring and progressing these different areas. I don't really care where we start, but if you're cool with it, maybe we just start with range of motion of how do you actually prioritize and discuss the range of motion from extension and flexion, and then, your own rehab, going through it. What have you found successful for improving the range early on?
Yeah. So when it comes to range of motion in particular, that's one of those that, swelling control is so important. This is, because people like get really stuck on range of motion and quad strength, in the early phases. And I'm like, working on swelling and calming the knee down is working on range of motion. Working on swelling and calming the knee down is working on quad strength. Those are the two things, because having swelling and irritation in that knee is going to restrict range of motion from a nervous system perspective. I mean, shoot, if you've ever watched an ACL reconstruction, when they finish, they bend it through full range and take it to full extension, full flexion, no problem whatsoever. The second that patient wakes up, it seizes up like crazy. So a lot of that is just nervous system fear. And again, back to that same thing. It thinks that this knee is trash. If you start moving it a whole lot, it's gonna really fall apart. And so that's that again, is that fight with that nervous system of getting it to actually fall in line there. And so the way you fight with it is not proving it right, which would be like grabbing that knee and trying to force flexion and pushing through a whole lot of pain. What you're basically reinforcing is movement equals pain, irritation, swelling, all these other things. And so my big thing is we are trying to coax things along. And it's that kind of balancing act between giving it enough input to show it that range of motion is safe and good and should be progressed, and versus not doing anything and having it kind of seize up on you, because it will seize up if you don't do anything. The body is basically just trying to seize that knee up into a stick that it can ambulate on. And it's not thinking about running. It's not thinking about jumping. It's not thinking about any of those other things. It's just like, can I get this thing even something I can walk on again? Which would be go ahead and just stiffen it up, lock it up straight, and here we go. I mean, it's just like wearing an immobilizer, which is what they do after surgery anyway. So you can walk on that thing. And so it very much is, let's just coax this thing along. And that's doubly true for flexion, because flexion usually comes as things calm down. It's the extension is the thing that we're really, concerned about, is getting that as quick as possible. There is the idea of a cyclops lesion, which is where you get some scar tissue that forms in the intercondylar notch, which is where the ACL graft should be occupying. And when you go into full extension, that graft takes up that space. When you're not in full extension, there's no graft there. And the idea there is, especially that a notchplasty, or a quad tendon autograft, that there's all this trauma right in that notch area, and it's going to scar in and fill in with that if the ACL isn't there. I'm not 100% convinced that we can prevent cyclops lesions. I think they just, if they're going to come, they're going to come. So I don't know that actually does that. But and you'll hear this a lot with my way of thinking. By working on extension, we are identifying when a cyclops lesion is forming and able to intervene quicker. We'll talk about that, like monitoring quad, for example, tells me when the knee is ready to take loads, because the quad will come alive, so to speak, as the knee becomes happier. And so that doesn't mean I'm not going to work on it. It means that I'm working on it to try to coax it along, but I may not be driving the change. And so same thing for extension. I want to work on extension, but I'm not going to be torturing them into extension with a whole lot of like hands-on, putting my body weight on them, really trying to grind it out. Because again, you're probably just fighting a nervous system more than anything than you are really stretching it. And, if you did have a cyclops lesion, the worst thing would be to just ream on it into extension, because the way a cyclops lesion works is it's occupying the spot. And so as the graft is trying to go into that space, it can't. And the more you try to push, the only way that you'll get the extension is not by getting the graft to go any further, but to get the graft to start coming out of the tunnels to give you more slack in the graft, so that you can get that final bit of extension. And there's some case studies where like surgeons have taken somebody with a cyclops lesion and done a manipulation under anesthesia, and they just stretch the graft out. So they knock the person out, they get the full extension, but they got the full extension by basically stretching the graft out to go around that cyclops lesion. And now, yeah, they can get full extension, but now they have slack and slop in the knee, which was the whole point of the surgery. So, kind of in summary there, extension definitely important. Most important, getting it as quick as you can, but you're just trying to coax things along more than, if you ream on something, you ream into a bunch of flexion, and then that knee just swells up because you made it so angry, you just undid everything you accomplished.
And that cyclops lesion, your perspective is it's maybe not really possible to reduce it from happening. It's just some people may get it regardless of what happens, and you checking in on and trying to improve extension. If that's not improving, that's when that kind of light comes on that maybe this is blocking it. You also mentioned like a quad tendon autograft. Do you find it more frequently in quad tendon autografts, and what timeline do you start to notice and then start to like bring it up with the surgeon?
Yeah, so there's some reports in the literature that there's a higher incident rate of cyclops lesions in those quad tendon autografts. I personally don't have a ton of experience with those. We definitely see them. Every one of them is a pain because they have a lot of pain. They're and in the end stage, they tend to be pretty temperamental as far as quad tendon pain. And you tend to be dealing with that at the end stage of the rehab. As I say with every graft, you pick your poison. People have been like poo-pooing the hamstring graft for a while because there's a little higher second injury rate with those. But when you actually look at like timelines, the thing that hamstring autografts are really good about is pain. They tend to be less painful. And so that means that they tend to go back a little too fast. And so I don't know how much it has anything to do with the graft, and it has everything to do with the speed of return. Contrast that with your bone tendon, bone patellar tendon bone, and your quad tendon. Those are both much more uncomfortable. And they almost always have some sort of thing that's holding them up on return that makes that return take a little bit longer. And it could just be that, when you look at the LAT procedure, which is the new little trick they've added where they kind of loop around the IT band to add a little additional rotary stability and they do that on top of a hamstring graft. They find that the second injury rate drops down to what you see in your quad tendon and bone patellar tendon bone autografts. But the one thing that the LAT adds is a little more time because they are very restricted in the early phases. And so it kind of delays your rehab a little bit. So again, maybe we could just do the hamstring graft and delay rehab a little bit and that would solve it. But that's just, we don't have those answers. And so that's kind of what we're stuck with that. But yeah, back to that original thing, the quad tendon, they are known to have a little more cyclops. And I think it's because they disrupt right there where a cyclops lesion would potentially form. I'm not saying that working on extension and getting extension absolutely will have no effect on a cyclops forming. But I've seen plenty of cases where they've worked on extension, they did everything right, and they still get a cyclops. So it's more to tell people who get a cyclops that, hey, this doesn't mean you did rehab bad. This could just be, these happen sometimes. And those are difficult to manage because, the surgeons like to say scar tissue begets scar tissue. So in other words, surgery caused this scar tissue to form. And the way we get rid of the scar tissue is with more surgery, which may cause scar tissue to return. So that the assessment is always, and this is where I'm always working with a surgeon to have this conversation, is the cyclops lesion bad enough to do something about it? Because we may go in there, do something about it, and it just comes right back the same way it was. You just added another surgery for no real good reason. So it has to be bad enough that you do something about it. Because I've had some tough cases where, man, and we ended up having to cast them into extension after surgery to prevent the cyclops from forming. They were casted into extension for a week before you take them out, because every time they would go in there, and the way the surgeon put it was that cyclops lesion is probably already forming before the patient's even awake from the surgery. So, yeah.
Yeah, the other options of why that extension isn't coming back, there's, I guess, other reasons, but would you say cyclops lesion is potentially the most likely, or there's, hamstring contraction or guarding? What other reasons why people may not be getting that extension compared to the other side?
Yeah, so if I have a swollen, angry, painful knee, that alone, the classic quote unquote closed pack position of the knee is fully extended. The way I put it to patients is, when your knee is fully extended, there's no real room for swelling to be there. So your knee kind of has to pop into a little bit of flexion to allow that puffiness to be there. And so this is where your swelling control can be a real big factor here for that. So they're walking a lot on it, they're not using their crutches, all these things that make a knee get really, really aggravated. That's going to limit your extension, and just the swelling alone is going to make it that they can't get full extension. But outside of that, I'm almost always going cyclops, is what I think.
Yeah, I have a patient right now that's 8 weeks out. She's quad tendon autographed for essentially this whole time. Uninvolved leg, she has 10 hyper. Her involved limb, it's really like at 0 sometimes, but lacking 2 or 3. Walking on a bent knee, 2+ a fusion. And I brought up they've been aware this whole time that that's been the priority and that it's not really improving. And I brought up the conversation to her parents and her last week that I'm concerned that there may be what's called a cyclops lesion, or I would love for the surgeon to dive further and for us to determine why is this not improving. But I just start second guessing myself of like, is it just this swelling that's not a cyclops lesion and we just need to calm that down? Or is the swelling because of the cyclops lesion, or, what it is? And then there's this guilt of, oh, I'm really delaying some of this rehab, but I'm not delaying it because I can't just push through this bent knee and the swelling. So it's this kind of spiraling that occurs as a new grad. But yeah, I think ultimately it's I think that should still be top of mind, like you're talking about. And then let's say it's not that. Have you found cases where you're like, okay, this extension isn't improving. We check, there's not a cyclops lesion, but it's still a swollen bent knee? Is it mainly just the activity and doing too much that's typically the cause?
Yeah, so a few things around that. One is, Occam's razor would tell you that it's probably the swelling that's limiting you. And the fact that you're close to 0 falls into the category of, even if you did have a cyclops, would you do anything about it? So a surgeon may kind of blow it off and just be like, I'm not going to give surgery on this, so why would I waste money on an MRI and all these other things, because it's not going to change our plan of care. We're going to keep, and they'll say, yeah, to keep working on it. Now you show up with a 10-degree contracture from 0, they're 10 degrees from extension. Yeah, then they're probably going to get, a little more aggressive with that. And usually their goal is to get them back to 0, not to get the hyperextension. Because again, cyclops lesions tend to keep coming back. So they're just trying to take down the big one, and hopefully a small one is what returns. So in that kind of situation. So unfortunately, the other thing that can often cause an extension, a lack of getting full extension back, is tunnel placement. And so that's one of those that it's tough as not being the surgeon, because there's nothing you can do about it, and your surgeon's probably not going to be do anything about it because it was their mistake, quote unquote, of where they put the tunnels. So if the tunnels are too vertical, then the graft is too far forward, so to speak, and it's usually the femoral tunnel that's too far vertical or too far forward, making the vertical situation. So by vertical, I mean as opposed to tilting back. So going from tibia to femur, it should go posteriorly and laterally. And so that's where, it was really popular for a long time there. And I think it still is, the transtibial drilling of the femoral tunnel as a technique does result in a little more vertical of a graft, as opposed to, and so what that means is when they drill the tibial tunnel, they leave the drill in the tibial tunnel and they just bend the knee and try to kind of twist the knee to get the drill bit to go into the femoral condyle and go right on through. So it's a lot simpler because they just do one continuous drive. But then when you go into extension, and you look at where the graft ends up, it ends up being a little too far forward in that spot. Some surgeons argue, oh, I get the same footprint. But what's become the more popular one was the one developed by Shelburne, which is you do your tibial tunnel, then you take your drill out and you go through the anterior medial portal that you're using arthroscopically, and you put your drill through that and go across the joint, kind of angled back through the femoral notch into that to drill through the condyle there, to drill through, in the notch, to get a better footprint and a little harder turn to create that. Because if it's too, you can imagine if it's supposed to be kind of seated back, but it's seated a little more forward, when they try to go to extension, the graft blocks you. And then you end up in the exact same situation that if you're going to get the extension, you're going to get it by stretching the graft out. So then you have to ask yourself the question, is it better to get the full extension and have a little bit of slop in the graft, or is it better to have a tight graft that you can't get full extension? Because the other alternative is you have to do a whole new ACL reconstruction, which may require a 2-stage procedure where they fill in those bone tunnels with bone material, have them ACL deficient for a while that heals. And then once the bone heals, then you go in and do a new ACL reconstruction, which is that much more complicated. So it's one of those that you got to be careful how far you go looking for it. But I have had cases that, when they're trying to return to play, they never quite get their full extension back. As they try to return to play, anytime they try to get towards full extension, their knee gets aggravated, their knee starts to swell up a little bit. You'll see the quad drop. And I've had a couple that it's like, it's a simple test. They just do an x-ray and they can see where the tunnels are. And, I think there was a study a while ago now, but I don't think it's changed, is that the average ACL reconstruction is performed by a surgeon that does, I think the number was 10 a year. So less than one a month. And there are surgeons that do, 2 to 5 a week. You can imagine the difference between the skill set of those two surgeons. And so if you're, you may find out that, and I'm not talking to your patient in particular, but, people out there might be dealing with a case that they're having a big challenge. And then they realize, oh, that surgeon does a lot of shoulders and they're kind of a general orthopedic. They do a lot of total joints. They do a smattering of some shoulders. They do a smattering of, maybe they've even taken on some hips. And then they fill in with some ACLs and they do one a month or so. When I have a case like that and they're several months out and we've been banging our head against extension and we're still having big problems, it's usually not a bad idea to get a consult with somebody that does nothing but knees, very high volume knees at least. And the first thing they'll look at is tunnel placement.
Yeah, that was going to be my next question about times when it's appropriate to seek another opinion and a consult. And I'm sure you have to tactfully navigate that. Do you have any words of wisdom of ways to go about that if that, makes sense or feels like it's time to seek?
Yeah, because you can have a surgeon that you work with a lot and that you don't want to be like, hey, maybe the surgery was done wrong. Or you're working with a team environment. And then you get into liability, which honestly is not usually a big factor. One surgeon put it to me, there's nothing illegal about being a crappy surgeon. So, things happen, but it's not even being a bad surgeon. It's just like, the outcome isn't ideal. When we deal, like, especially with like college athletes, this is really kind of sticky because you can be the team physician that did the surgery. And now you're looking at, I have some concerns about where you are right now. And what you try to do is facilitate a request from the patient. So you have to make it the patient's idea. That's the easiest way to do it. So the patient asks you, yeah, I was thinking about a second opinion. And you're like, yes, thank you for saying this because here's the person I think you should see. And you always play that off tactfully and just go, yeah, and hey, look, as your own, professional, you should be like, hey, I don't know. The outcome I'm getting is not ideal in this case. I'm not saying that I'm doing anything wrong here, but hey, let's get another set of eyes on this. Hey, there's this person down the street that sees nothing but ACLs. Maybe see them for a visit or two and just see, is there something? I mean, I do that all the time for other physical therapists where it's like, yeah, let me, I'll do an ice kinetic test. Let me see what I got. Here's some things to think about. Maybe this will alter your plan of care. Take this back to your PT. Here you go. As a professional, you should be comfortable with second opinions, and that should be a normal thing. And most surgeons actually are. And so if the patient says, the surgeon I've been seeing, they just keep telling me, keep working on it. And I'm starting to get dissatisfied with that answer. What do you think? And you go, well, you could get a second opinion, if you feel like you're not getting the answers you need from the surgeon you're working with. The best way I always think about it is imagine that your patient went back to the surgeon and said, hey, that physical therapist, I like them. They're great. But it just seems like they don't have any answers for me at this point. And in all honesty, you're probably sitting back going, yeah, I don't have any answers for this person anymore. Would you be offended by the surgeon going, here's another person maybe for you to look at? And if you would be offended by that, that's your problem because you shouldn't be. That's just part of the job.
Yeah. And that's the value and what's so nice about either being in a clinic where you have other professionals that you trust, that you can seek opinions and thoughts when there's these messy situations, and maybe co-treat or offload to that therapist that may honestly have some better options, or be in a city where you know of other clinicians to get feedback. Same thing with surgeons. Hopefully they're open to their colleagues providing some input.
Yeah, it takes a ton of self-confidence and self-awareness to be okay with getting help as a professional. It's counterintuitive because you would think people who admit that they don't know and could use another set of eyes are ignorant and stupid and all these other things. We see this a lot in pro sports where I'll have somebody, like they'll consult with me privately on their own dollar as a professional because they cannot let the team know that they need help, even though it's perfectly normal to need help on a complex case. You think of like somebody working with a pro team, like an NBA team. You know how many ACLs they see in a year? Hardly any at all. I mean, it's not normal for them. You know how many somebody who works like in an ACL clinic, so to speak, sees in a week? I mean, again, it's back to the same thing. It's just you just don't have the volume. And so reaching out and getting help. And I do like it when a team builds that culture of we're going to reach out for help and understand that we're looking for a really good generalist that can handle lots of different variety of things, but they are not necessarily an expert on any one particular thing and will often be pulling in others. But that's not all the fault on the medical side, because I've literally been in a practice facility and the person who brought me in introduces me to the general manager, and the general manager literally says in front of that other therapist, oh, this is the guy you brought in because you can't do your job. Why are we paying you all this money and you can't even do your job? That's not cool. And that's a complete misunderstanding. And we see that a lot in pro sports, is that the front office has no understanding of what their day-to-day medical staff knows or does. I've heard it put that they see the medical staff as firefighters, meaning, it's a job that you were trained to do that is completely interchangeable, that everybody should be able to put a fire out. I mean, it's just a simple, like, just tape an ankle. I mean, how complicated is this job? And they don't understand the personality complexities of doing it right. And when you would need to pull in additional help and additional experts. And the way they see it is, oh, we could just get rid of this person and get somebody else, some new grad who would do the job for a lot cheaper, who has, who has a degree and a license, which is all we need. So, yeah.
Going back to how important it is to manage swelling and calm the knee down to regain and normalize range of motion and get the quad kind of back online. Besides just the discussion around managing time on feet and not doing too much activity too soon, have you found strategies to calm the knee down and to reduce or manage swelling early on?
Yeah, I mean, my big thing is altitude, so to speak. So, you think of, back to your basic, physics laws like Boyle's law and whatever, you got a column of water. That's what you have. You have a big old bag of fluid and you're trying to drain it. The higher the column is in altitude, so to speak, the more pressure downward is going to be created. And so, if you have a water tower in your neighborhood, that's what creates your water pressure at your house. If you are lower from that water tower, you're going to have better pressure. If you're closer to the same height as the water tower, your pressure is not going to be great. If you're higher than the water tower, it's going to go backward. And so remember that fluid ultimately is going back to the heart. And so to be kind of processed, so to speak. And so we got to get that knee as high in relation to the heart as possible. And so just laying on your back with your foot, propped up on something, 12 inches, that's not how we're going to do it. We're going to bring that all the way up. What we do is we put them, with their head away from the wall. We slide them all the way up till their butt is about hitting the wall, and we put the legs straight up in the air. We'll put an ice pack on there because I don't think ice hurts anything. Whether or not it helps doesn't matter. I think it often can be more comfortable. I'm happy to put some E-stim on there too if that makes them more comfortable. I mean, you're just trying to get them to tolerate the position. And then we use compression. So a good old ACE wrap wrapped around that knee while it's up in that position. And then gravity, and let them be like that for a while. And then, especially if I have a chronic sweller, a lot of, issue with that. Typically what you'll see is that you got the swelling down pretty good after being up like that for 15, maybe you'll go 20 minutes. Then we'll pull a sleeve over the, compression sleeve over the knee before we lower the leg. And so I talk about it like as a bucket of fluid. And so, when you put it down, it's going to fill up with fluid, that bucket is. And so what you're trying to do is make the bucket as small as possible before. So the container is just not big enough. And that's what the compression, that's the thinking behind it. I'm not going to say I can cite a bunch of studies on those strategies, but that's kind of your common sense strategies of just using basic physics around it. And I do find that the compression sleeve usually makes them a whole lot more comfortable too. They tend to like that, obviously, that's an old DVT thing too. If somebody has a DVT, compression sleeves, like crazy for them. But that's what I find works well for that swelling, for management, doing that. And then again, minimizing how much they're up on it. Cause again, it's a bucket. The more that bucket is in the dependent position, the more it's going to fill up. The more it's in a, up in the air, the less it's going to fill up. So getting them off their feet, getting that leg as high as possible, as often as possible is kind of key.
One more question about the extension piece. If someone's presenting with like 15 hyper on the other side, how much do you care about getting fully back to that much? Or is it also when they're that kind of hypermobile, it's probably going to come back? But is the goal always to get essentially symmetrical to that other side?
Yeah, but like you said, if they're that hypermobile, it's usually not a problem. They're not the kind of person that's going to have that big issue. But yeah, I am a believer that when you're doing rehab, you're trying to restore them to whatever their baseline was. That's your goal. And so now whether or not so we were just talking about like the possibility of a small cyclops, what do you do about it? Well, is it good enough? Yeah, there's your goal, there's good enough, and then there's unacceptable. And so I would say, yeah, getting it to whatever they have on the other side is probably what they had on their involved side. Getting it to that should be the goal. Anything better than 0 is your, good enough. And then unacceptable is you can't get to 0, and they naturally get past 0 on the other side. I have had people that full extension on the other side is 0. And so then I'm going to be a little more lenient on that.
Managing swelling and normalizing range of motion, we're chipping away at those. Like you said, waking up the quad can come from the swelling management, but what are ways that you're actually directly addressing starting to get a voluntary quad contraction?
Yeah, so we start quad isometrics really early, and I think that's really, really key. And I do totally volitional, unassisted quad isometrics. Basically, once we can get them past 60 degrees, for simplicity's sake, for home program, it's always at 90 degrees that we have them do the quad. When you think of quad set straight leg raises, you're doing it at full extension. You're basically putting the muscle at full slack and asking for your contraction. It's just not a great position to do. If you were to try to do an isometric on your bicep, you wouldn't put it at terminal flexion and then try to get a contraction there. It's not going to be a great contraction. It's just not a good length tension ratio. And so, yeah, get in the mid-range ideally. 90 degrees is fine. It's a little past, but especially with the quad tendon, the more flexion, the better, because you're going to be really kind of stimulating that rectus femoris, which is where they pulled the graph from. But yeah, and I always start with a 45-second hold with the idea of I'm just trying to get this person comfortable with the sensation of putting load through their knee in this way. So it's a nice, gentle, hold it for 45 seconds. And then, if you can have it on a dynamometer where you're getting real-time feedback as to what the number is, I think that can be valuable. We always start with a pain measure as our dosing tool. So I say, I want you to feel some discomfort. You should be, 3 or 4 out of 10. If it drifts up to a 5, well, back off, keep it at around a 3 or 4. If it drops down to like a 1 or a 2, well, push harder. You're trying to hold it at that sensation type load. And so using sensation as my loading thing more than like what the dynamometer is saying, I think for me is important. And then we track what the dynamometer is saying so that we can say, oh, at this pain level, this is the force that they produce. And so a lot of times you'll see their pain doesn't change, but you see the force creeping up and you're like, okay, that's progress, even though they don't perceive progress because their symptoms are not changing. You're seeing that change on the dynamometer. So, yeah, I do a lot of that. There's you can do NMES. That's a very popular thing. People push it a whole lot because of the fairly not particularly recent research. This is like 20 plus years, going on 30 years now that research was being done. And unfortunately, most of that research is comparing it to not doing NMES, but not comparing it to doing isometrics at a bent position, getting that volitional contraction in that way. With NMES, it should be done non-volitionally, meaning you should do an MVIC test. How hard can you kick in that bent knee position? And classically, it's done at 60 degrees. How hard can you kick? And then whatever that is, while you're totally relaxed, you crank the stem up until your leg is kicking at 70% of that MVIC with no volitional assistance to it. That's a very intense contraction or amount of stim that you're putting on somebody. And that's, to me, that's also very unpleasant. And a lot of times I need to ask myself, and I've always asked myself, if I'm going to make somebody go through something this unpleasant, I better be darn sure that this is doing something and is helpful. Now, why not adding the volitional part to it? My thought process around that is the problem with the volitional contraction, we just talked about, you're doing like a 45-second hold. That's going to be a slow twitch type engagement. When you engage volitionally, you're getting slow twitch fibers. If you use the stem, that's going to bias your fast twitch fibers. And so the stem is going to be basically hitting those fast twitch fibers. My And I'll say most of our high level athletes, because they're like, I don't care that this is uncomfortable. If this is going to give me the slightest advantage, I'm going to do it. And I'm like, yeah, it's not going to cause you any harm. Knock yourself out. Let's go. And I'll teach them how to do it, and we'll do it. It gets into those other cases where it's like, I leave it up to them. And usually a lot of people are like, yeah, I don't like that. I don't want to do that if I don't absolutely have to. Because the criticism I would have of it is, all right, so we're 6 months out. Did it matter? Or did we get it back now? And a lot of people say, oh, well, there's all this research that shows the quad really hasn't come back, or they do muscle biopsies. It's not. It's like, yeah, we also know that people are chronically underloaded in their quad during rehab. So does that have anything to do with, those strategies, or just load it? Because one thing NMES is a form of load. And so if you're doing nothing else and doing NMES, that's going to be a whole lot better than not doing the NMES. And so that's always been my argument for it. So again, I'm not saying it's bad, it doesn't work, or any of these other things. I just don't know that it is like it must be done. BFR is another one of those, blood flow restriction. Very similar type thing. It's going to tend to bias those faster twitch muscles, that hypertrophy type response. It really is going to hit all that. But when you look at the studies, you start seeing, specifically around ACL, yeah, it kind of jump starts things a little bit. But man, when you're getting out that 9 months out, it all kind of bogs down to the same spot. And so did you really make a huge change at the time point of return to play, which is what the athlete really cares about? And so back to that same thing, doing BFR tends to be not the most pleasant experience. And so back to the same situation. Do I have high level athletes who are like, yes, give me the BFR, give me the NMES, yeah, we're going to do all that. But is it something I'm saying this is absolutely 100% medically necessary for you to have a successful outcome? I can't say that. And I have a hard time saying that, honestly. And so again, this is where it falls under this is something that I can offer, but it is on the patient to decide that they are going to do this, not something I'm going to say, if you're going to work with me, you're going to be doing this process. Because I have a ton of patients, even very high level athletes, that are like, nah, man, that sucked. I'm not doing that. I don't care. That is not something I want to do. It's like, that's fine.
Yeah, it sounds like if you're already seeing these, force production numbers going up with these isometric tasks, you're introducing progressions as weeks go on, and you're realizing that the quad and the knee can tolerate more and more. Is it substantially more beneficial to add on those other pieces?
Yeah.
It sounds like maybe not, but if people are open to it, you have the resources, you have the time, you're not seeing maybe some of those changes, maybe those are the times. But I also, I've gone through it of feeling this almost neuroticism of, I gotta, set on this BFR and have them do it, or all these things. And just in the logistics of a typical clinic, that takes time.
Yeah.
And is it more worth it of just having really productive, intense isometrics and other forms of loading without going through the hassle of setting up a BFR or setting up the NMES if those things aren't readily available or you're time constrained? And like you said, is it a wash by the 6 or 9 month mark if it's a otherwise appropriately loaded plan?
Yeah, and not to mention those isometrics can be part of a home program. Part of a well-balanced breakfast, so to speak, is that they get their isometrics in. Whereas NMES, yeah, there are devices. They're really expensive, the ones that can put enough output to get what you need. They're not cheap. So for somebody to use for home, that can get a little costly. And then same thing with BFR. You can teach somebody how to use knee wraps and more of your primitive type things, although then it gets a lot more complicated. And I don't know that your patient education is going to quite match up for that. There is the CPR argument, so to speak. So you're doing CPR on a muscle to maintain so it doesn't atrophy while it's not getting its volitional contraction, that full signal from the nervous system. The AMI is blocking it, the arthrogenic muscle inhibition. And so using BFR and NMES as a way to kind of keep that thing from atrophying is definitely an argument. I could see the value to that, but again, back to that same thing. But does that matter down the line when you've got a 9 to 12 month rehab? Potentially you get that back. And the counter argument is, but maybe you don't get it back. And maybe specifically the fast twitch fibers. And you can see how the argument goes back and forth. And I don't have an answer that's clear, but I have a process that I use for when I manage that. I'm the one who's more likely 9 months out, and I've got somebody that's just been stuck with a number on their quad output that has just been stuck for 2 months. And it's just like, they're stuck at like 75% or 80%. And they're like, I just can't get it to give me anymore. I put all my might into it and it just feels like I can't get that quad to engage any further. Yeah, man, that's when me personally, that's when I'm like, hey, you know what? Let's try some, let's do a BFR sequence series with you and let's see what kind of response you get. I will also say, and I tell them this as well, is that a lot of times a little more time and all of a sudden your quad comes on. And so it could just be that, or it could be the fact that we tried this. It could be, we try some NMES or something like that. You just start throwing some things at somebody just to create some variety. Maybe you're just trying to create novel stimuli for the quad to react to, and maybe that makes them break through that stall. Or like I said, maybe just a little more time went by and it broke for that reason. I love to tell people that I love getting second opinion cases because, they've been stuck for a couple months and then they come see me and it's like all of a sudden they're doing a whole lot better. It had nothing to do with me. It's just that they happened to switch to me right when it was going to break anyway.
I guess maybe an argument for some of those early on is if it's like a meniscal repair and they can't get into some of those bent knee isometric positions and they have to stay straight leg, maybe some, alternative options to get some type of quad stimulus if the leg kind of has to stay straight early on. Would that be an argument?
Yeah, sure. Back to all the same other stuff. I will also say, some of the best cases I've had are ones that had some complexity where the surgery, like all they worked on was range of motion. Like they were like partial weight bearing, braced, and all they were allowed to work on was range of motion and swelling. And that was it for 6 to 12 weeks. And man, the knee is so happy and calm and everything's great. And you do that first quad test, and it's like, woo, that quad actually looks pretty good because everything's happy. And then here we go. And then it's just a matter of, I just need to restore things. I do think that a lot of times we hammer on these things so aggressively in the first, 12 weeks that the knee is just like, it's like shell shocked, it's kind of like PTSD from all the stuff you've thrown at it. And it just needs a break, and it's just beaten down, and that's what you're actually seeing, and that's what some of this dysfunction is. I'm a very much a less is more kind of person when it comes to a lot of that stuff because, I see all these cases where, they're 3 months out, so they started running no matter what, and then they 4 months out, they've got them doing jumps, and they've got them doing all this like muscle movement retraining type stuff, and it's like, yeah, but their quad isn't putting much force out. There's no way they're able to do those with any sort of normal mechanics. And so now they're learning all sorts of different things. So now you have this person with an irritated knee who's learned all sorts of strategies to unload their knee that moves all weird because of all this. And it's like, if you would have just literally done nothing and just said, you know what, just take it easy for 6 months and just do whatever feels natural, but don't run, just work on range of motion. And then I'll pick you up at 6 months. I wonder what I could accomplish in the following 3 months and where I would actually have them by 9 months than if I had started on day one, like hammering at stuff, where I would have them at 9 months. I don't have an answer to that, but I'd be curious. Obviously you I don't think it would go well if a patient came in and said, we're going to do nothing for 6 months. And then we'll start then. If you're working with a team, you'll probably lose your job.
Yeah. The last thing I wanted to touch on and hear your thoughts, because I think you've alluded to it in some of the courses I've attended of yours, but this idea of gait training and really trying to retrain their gait. What are your thoughts on how to, one, I guess, wean off of crutches in an appropriate manner, but then this idea of like teaching someone to walk again?
Yeah, I mean, there's so much variability in human movement that your first problem is you don't know what normal is for them, because what you're looking at is abnormal for them because they just came out of surgery or they're on crutches. I mean, you can't walk normally on crutches, full stop. You can't do that. I do show a lot of like some of the like machine learning type stuff, or not machine learning, but training like robots to move and that kind of thing. Sorry, I'm getting into the technical terms of like, well, that's technically not machine learning. It's technically this. No, so don't worry about it. But like how you kind of reinforce, their movements. And what you find is, so like the reason somebody's limping is because it's the optimal way to move with the constraints that they're presented with. And the constraints can be swelling, loss of range of motion, pain, any of these other things that they're like, I have to alter my gait to be functional. And so when we put them on crutches, we allow them to unload the leg and use it as quote unquote naturally. So it looks a little bit like a more normal movement pattern, but it's accommodating pain and all these other things. So they don't have to deal with those problems because the crutch takes some of the load off. And so, but the idea there is that first you have to make sure they have the capacity to do that task before you start training it. And what you typically find is that, eventually, once they get the capacity back and you let them just kind of do their thing, it'll figure it out kind of on its own. The thing I always say is like, if someone breaks their leg and you put them on a bike, they're not going to ride the bike very well. But you don't need to like teach them how to ride a bike again. You just have to let the leg heal and then put them back on a bike and they'll remember how to ride a bike. It's fine. And then people will talk about like, but they're learning all these new compensatory strategies when they're walking. It's like, yeah, I mean, if they're that adaptable, they'll probably adapt back naturally. But also it would probably fall more on the line of, I'm going to wait until everything's restored and then see how they're moving and then chime in. Because I've had cases where, everything looks good and then we have them do stuff and they're moving funny. And you're like, wait a minute, can you try doing it this way? And they try doing it the other way. They're like, oh, there it is. Yeah, and very quickly they've got it. It's not a matter of any like really complex relearning. Because when you get into, they're going to fall, most likely, they're going to fall back into whatever strategies they had prior, as long as they're not constrained into some other strategy. And so that's why I'm a big proponent of tracking those quadriceps, because if the anterior knee function is not there, they're going to start being forced to use a stiff knee strategy because they don't have a bent knee strategy. It's been taken away from them. Then they start moving in these ways that are consistent with a stiff knee strategy, which includes valgus. And so I see too many therapists like late in rehab, they're not testing, the force output of the anterior knee or force tolerance of the anterior knee. They're just looking at the person moves and they go, oh, that's a bad strategy, not realizing what they're seeing is actually just poor anterior knee force tolerance or load tolerance or function. And so then they try to like fix that strategy. And it's like, that's a strategy they're constrained into. You have to take the constraint away. You can't fix it without doing that. And a lot of times once you take the constraint away, then they fall back to whatever their original strategy was. And now you can make an assessment of that. And the problem there is if you decide you're going to change that, that is not an easy task. That is like very complex, a lot more complex than we think. You can get somebody to do something in a clinic environment with a lot of cueing and a lot of internal intention coming from the brain. But the second they get out into a chaotic situation, specifically like sport, they're gonna go back to whatever strategies have served them well in the past. And so that's the problem you have with trying to change somebody's strategies. But what I keep teaching is in a rehab situation, first off, you probably don't know what their original strategy was, and you're not going to see it until everything else is checked off. So once you have everything else checked off, then you can take a look at what that strategy is. And now you decide, oh, I'm going to change this. All right, well, that's going to be another 9 months of work to truly change that strategy. And that gets kind of into the coaching side. And we deal with that. Like I deal with high level athletes because I just had one, watching her get back on the court as a professional basketball player. And she goes into that quote knock need position every time she shoots. And I'm like, yeah, I mean, I see that. And she goes, oh yeah, that ain't changing. She goes, people have been telling me to change that for years. And it's like, I've tried, I've done this, I've done that. And it just all falls right back to that. And that ain't changing. It's like, yeah, no, that's not changing. And the big problem we have, especially with elite athletes, is that can be something that they use as an advantage, that they move in a very particular way, that may be throwing off another player. And that's why they're successful, is because they move in this way that the other player is like, whoa, what? And that's what makes them successful. But also you may find that, first you have to decide that it's normal for them. And that's going to be what they fall back to. Then you have to decide that's worthy of change. Then you have to change it. Now that you've done that, now you have to assess, have you made them a worse athlete for their sport? Which may be that, we see this from a performance perspective, like a quarterback, for example, that in college, their delivery, when they throw the ball, they like to lower the ball really low on their windup and then throw it. Well, that's a huge liability when you get to the pros, because a professional defender is going to strip that ball and cause a fumble every time. So you got to coach them not to do that anymore. But you may find that when you coach them not to do that anymore, they now can't throw the ball down the field, because that was their strategy to generate the torque to throw that ball down the field. So you're stuck with, I've now made this person a subpar athlete, but I fixed the problem. And so when it comes to, like, from an injury perspective, it's like I made them safer, but now they don't play anymore because they're not good.
Yeah, was it worth it? And did you just have them lose their position or career or make them worse? Yeah, this was great. Is there anything else within this early phase or stage that we haven't touched on that you want to briefly highlight before we wrap it up? Or even like Erik 15, 20 years ago, what you don't do anymore, or what you've brought in?
Yeah, I would say the big thing that I don't do anymore from way back when is I used to think it was important to be working on quote unquote coordination training through the whole process of rehab on an ACL. And now that's what I look at it as, is expanding capacities. So as they have more capacities, I open up what they do. So weirdly, on the same note, I get a basketball player back on the court as quick as I can. Like, just be on the court. Start shooting free throws, shoot them from a chair. I mean, get them back on get them in their environment as quick as you can. And then what you're doing is you're just creating a larger and larger sandbox for them to play in. That's the way I think about it, and let them free play in the sandbox. So the thing is you're just you're taking away constraints. So it's like, well, and honestly, like acceleration, you don't need anterior knee force to accelerate. It uses very little anterior knee when you're accelerating. It's deceleration going into like a change of direction. That's where you really need it. And so that's the thing that's going to be very, very late in the rehab, is any sort of change of direction. And more importantly, until they can decelerate, that's everything. Once they can decelerate, then we look at how everything else kind of goes out. Sorry, my notifications are going off. And so I used to think, oh, but we're developing the coordination system. The problem we have is that coordination is not a thing. People are not coordinated. It's task specific. So I can be really, I like showing a video in my current version of my course. I show the Utah Jazz. All of them had to like draw something. And so their hand-eye coordination is just awful. Trying to draw the Jazz logo, that's all they're doing. And it's just terrible. And it's like, they don't have coordination as a thing, but you can't say this person is uncoordinated. Look at them play basketball. It's task dependent. So working on like somebody's like balance system, it's like, it's dependent on what you're asking them to do. And so it's not something that you can develop and then act like it's going to transfer over. Strength and force production, that transfers, because your ability to generate force is your ability to generate force. And so that's where my focus has really been there. And then that's something I've been more and more, especially lately, is much quicker to get them doing things functional, quote unquote, as part of their sport as quick as I can. Get them engaged in that way. I mean, shoot, somebody who's off crutches, no brace, no swelling, they can be dribbling on a basketball court. They can be walking through plays. That's perfectly fine. They can be doing little spin moves. They can be doing, again, all these little low intensity things. Yeah, let them play around with that kind of stuff. And we let them do that like much, much earlier than we used to, me personally. And so I think there's a lot of value to that. And I think that's the retraining. So get away from formal, coordination, neuromuscular re-education type exercises, and just think of that sandbox. Create a sandbox, let them just free form play in that sandbox. Then a bigger sandbox, let them free form play in that. And this is what we do, is we are tracking anterior knee tolerance, because that's our canary in the coal mine. That's the thing that's going to show us how their knee is doing. And we can just use it as a percentage and say, right now you're at 60% of what the other side is, and the other side is giving us a good normal forceful output. You're about 60%. So I'm going to keep you at like 50% intensity as you just kind of move around through space and work on some things. So it's a very free form type situation.
Erik, this was a great conversation. Let's call it there. I think that was a great spot to end. We'll include all the courses, conferences you're attending in the show notes. Thanks for coming on for round 4.
Yeah, absolutely. Thanks for having me. It's always fun.